Good evening, everyone. Thank you for joining us for our virtual health talk this evening, Common Hand Issues. Our speakers are Dr. Jonathan Macklin and Dana Molina, who is a certified hand therapist. So my name is Rich Riley. I'm a member of University Hospital's Marketing and Communications team, and I will be your moderator for our event this evening. I'd also like to recognize my colleague, Kelly Crow, who's played an integral part in planning this evening's event as well. On behalf of the entire University Hospitals family, thank you for joining us for our webinar on common hand and wrist issues, their causes, as well as non-surgical and surgical treatment options. As most of you probably know, pain in the hands and wrist is more common than ever. Conditions such as carpal tunnel syndrome, trigger finger, tendonitis, and arthritis can affect your everyday activities and overall quality of life. Before we begin, just wanted to share a couple housekeeping notes with you. In this current platform, as attendees, you're all muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed during the course of this presentation, please submit your question through the Q&A feature, and our presenters will address questions at the end of tonight's presentations. Also, this evening's webinar is being recorded, and as a registered participant, within a week or so, you'll be getting an email that has a link to tonight's presentation in it if you choose to watch this again or share it with family and friends. So it is now my pleasure to introduce our presenters. Dr. Jonathan Macklin is a fellowship-trained orthopedic surgeon specializing in hand and upper extremity surgery. Dr. Macklin received his orthopedic hand fellowship training at the University of Connecticut. He completed his residency, internship, and research fellowship training at Case Western Reserve University in Cleveland, Ohio. He earned his medical degree from the University of Pennsylvania School of Medicine and completed his undergraduate degree at the University of Pennsylvania, where he was recognized on the Dean's List and as a university scholar while competing on the men's varsity lightweight rowing team. Dr. Macklin is active in academics and has contributed several articles and book chapters. He served as the editorial reviewer and associate editor for the Case Orthopedic Journal for the Department of Orthopedics at Case Western Reserve University. Dr. Macklin is a member of the American Academy of Orthopedic Surgeons, the American Society for Surgery of the Hand, and the American Association for Hand Surgery. Our second presenter, and joining Dr. Macklin tonight, is Dana Molina. Dana is the team lead at UH Geauga Medical Center's rehabilitation program at the Geauga YMCA. Dana has been an occupational therapist for 23 years, working at UH Geauga Medical Center for 19 years. She holds a specialty certification in hands and has extensive education on wound care. So ladies and gentlemen, our first speaker of the evening is Dr. Jonathan Macklin.
Thank you very much for the introduction, Rich. So as he was saying, tonight we're going to talk about some common hand issues, identifying a few common issues, kind of talking about how those problems are diagnosed and exactly what they are, and also treatment options. And we're really lucky to have Dana here with us tonight, who's one of the hand therapists that I rely on to help out with a lot of the non-operative treatment options. So she'll be giving us a lot more insight into that part. So excited to hear from her as well. And then at the end, there will certainly be time for questions and answers, whether that's a topic we specifically touched on or something else that you wanted to ask either of us. So the three things that we're going to focus on tonight are trigger finger, basilar joint arthritis. What that is arthritis at the base of the thumb, and also de Quervain's tenosynovitis, which is a tendonitis also towards the base of the thumb. So kind of starting off talking about trigger finger, what this is if you look at the picture here, you can see the black areas are the bones, and the green and blue lines are supposed to represent the tendons, And what can happen is that either there's swelling of the tendon, or what can happen is that you can actually have kind of constriction of the band that tendon actually runs through. There's kind of a tunnel, so to speak. And what trigger finger is, it's when there's relative stenosis, so there's tightness of that, and that can either cause the finger to actually pop. So when you go to open the finger, it pops open, or sometimes you'll just feel a grinding, a lot of times some soreness at the base of the finger. So, a lot of times these symptoms are worse when you first wake up from sleep. The reason why that can happen is when we sleep, we all tend to sleep with our hand in a flexed position, which can allow that tendon to swell a bit more. And what can happen is the finger can actually get fully caught, and some people actually have to use their other hand to open it, or sometimes it just pops a few times. A lot of times, because the tendons aren't working properly, patients, instead of complaining of pain where the problem is really originating, which is down here, a lot of times patients will actually have pain out in this joint over here. And on physical exam, what I'm looking for is to see, number one, is there actually some popping? And also, sometimes patients will actually come in and they actually can't move a finger, and it can be any of the digits. Sometimes they can be stuck in extension, so you can't bend it down because that tendon is so stuck. But a lot of times what we most commonly see is that it'll move, but it'll kind of pop as it goes. And, observation is one of the treatment options. This isn't, necessarily a great thing, especially if it's been going on for a while, because typically the longer it's been going on, the less likely it is to go away on its own. Sometimes we talk about anti-inflammatories, so things like Motrin, Aleve, what have you. I'm not going to talk too much about splinting because I know Dana's going to get into that. And another thing that we talk about is corticosteroid injection. The steroid injection the goal being to reduce the inflammation there, and that a lot of times can have pretty good success, but we'll talk a little bit about kind of when it may not be as successful. And ultimately, if none of those things work, is when we start talking about surgery. So when we talk about a steroid injection, we know that tends to be pretty successful. So a single injection usually solves this for at least 3 to 4 months in about 70% of the cases, but it's unknown for how long. What we know is that patients with diabetes tend to not have as great as a reaction to that. And the other issue is that patients with diabetes can actually raise their blood sugar for up to 5 days afterwards. So in a patient where an injection may not be a great option, that's where therapy can be very helpful as well. And with that, I'm going to turn it over to Dana so she can talk a little bit more about some of the therapy options.
Well, good evening. You're seeing me from my home, so forgive me if you're even seeing me, I don't know. Basically, with the trigger finger, once it starts to trigger, it's painful. So we first have to get the pain away. Sometimes we might splint the whole finger and just kind of let things rest. That won't last for too long. But the biggest thing we do is to avoid having the tendon go through that pulley where it's catching. Best way to do that is to splint the first knuckle, as you can see in the picture. Splint it so you can't make a full fist. And as Dr. Mackin explained earlier, we sleep like this, so we tend to trigger and you get a lot of pain. So if we can avoid that, sometimes we can have patients just wear those at night and they're fine. And other times they're bad enough that we have to splint them like that all the time. There is some exercises we want them to do if they wear the splint. We want to make sure that they keep the other knuckles moving. So you kind of make like a hook with your fist and just keep all the other joints in the hand moving. And then eventually, hopefully, if we can keep going, we advance to taking the splint off and doing what we call a place and hold. So you go into a total fist, hold, and hopefully we can move forward. We also explain massage it. That's kind of our natural reaction when we hurt ourselves, is to massage it. That's actually a good thing. And then if that doesn't work, then we go back to Dr. Mackin on that.
Okay. So ultimately, if we are still having issues despite conservative treatments, then that's when we start talking about surgery. This is a surgery that is done in and out the same day. And the nice thing is that we don't really have to slow patients down other than the fact that there is an incision. So that does have to be protected. The incision kind of goes right at the base of the digit. And it's something that can actually be done using local anesthetic only if you want, meaning you could even drive yourself in and drive yourself home. Or some patients do elect to have a light anesthetic, but essentially what we do is we go in, and I'm going to go back to that other slide. What we do is we go in and release, kind of, if you see this purple loop just right next to the blue kind of oval. I don't know if my mouse is showing up, but we go in and release that part to take the pressure off of the tendon. And that typically solves it, and very, very low recurrence rate after that. So kind of moving on, and then after that's done, if there are any issues, but this is again where Dana steps in.
Right. We don't typically see a lot of patients that require a lot of therapy after they have the trigger release, to be fair. It's usually those that have diabetes or are just over scar, that, or have had other things going on. Basically with scar management, I just wanted to kind of put it out there with any scar, just applying lotion such as vitamin E, cocoa butter over your scar. It'll soften it. It'll aid in removing the old skin and debris. We prefer Eucerin. That's what I use at Geauga. It is pH balance, which just means that when we put it on our skin, it doesn't change our skin's protection abilities. So in other words, we have a certain acid that sits on our skin. If we use kind of cheap lotion or lotion that have scents and stuff, they tend to really nullify the acid on your skin. So something pH balance like Eucerin is good. And then we move forward toward really being more aggressive with the scar. There's products out there that we do recommend. There's Sikacare, Mederma. Mederma. I think that's it. Silopad, things like that can help lessen the appearance of the scar. But I want to point out that the main reason we do scar management is to make sure that nothing underneath that you can't see is getting adhered to the scar tissue. Next slide.
Yeah, thank you. So as she said, I think, for trigger fingers, that's a lot of times we don't tend to run into scar issues. A lot of times it can be more, I think, I rely on them, especially in trauma situations or more extensive surgeries. The vast majority of people do pretty well without therapy after something like a trigger finger release, but we have a great team to take care of any issues that might arise. So kind of moving in to talk a little bit more about the basilar joint arthritis. So this is something that we certainly see much more often in females, but still see quite frequently in males. They haven't quite figured out exactly why that is the case. They've looked at anatomic differences and tissue laxity differences, and nobody knows exactly what it is that causes that. We do know the incidence of this increases with age, as many arthritic conditions do. And in patients that are over 55 years old, and females over 55 years old, over 30% of patients actually have some degree of arthritis there. Typically, we'll see worse symptoms with advancing arthritis. That's not always the case. So I will have patients that have not bad looking x-rays that have a lot of symptoms, and patients with really bad x-rays that seem to be doing pretty well. So really the most important thing is that we treat the patient and not the x-ray. So you'll notice that these hands in this picture look a little bit younger. That was a pandemic activity helping Dad make some new pictures for his slides. So that's a 5-year-old and 8-year-old hand. They do not have arthritis, but they were kind enough to lend their hands. So, what we see a lot, though, the biggest thing that patients will come in complaining of is pain, especially with pinching and gripping. And the reason why those activities are so difficult with this type of arthritis is because when you grab like that, it creates a downward force, and our joints are really good at taking forces that push directly across. They're not so good at shear forces. So when a joint gets pushed together and slides, that's where pain can be generated, and both of these tend to do that at the base of the thumb. So this is typical x-rays that we can see. So a lot of times, this one on the far left, the joint at the base of the thumb, actually we see it widen a little bit. The reason why that can happen is that there's actually some inflammation that causes the joint to widen. And then we start seeing it narrowing as the padding in that joint becomes less and less, to the point where you can see all the way to the far right, a lot of times there actually will be arthritis that develops on the other side of the joint as well, which, if we are treating this, that's also something that we need to address. So when we look at, what kind of symptoms patients have, there's usually tenderness kind of at the base of the thumb here. Sometimes patients will have pain radiating into the whole muscle group here, just from some of the inflammation there. A lot of patients who have this type of arthritis, about 50% in fact, also have carpal tunnel syndrome, which is also something we're on the lookout for. And then, as I was saying before, this tends to be symptomatic when the joint is sliding. So when we're testing for it, we try maneuvers that kind of force that joint to slide and see, if that's what's causing the symptoms. As far as treatment goes, I'm not going to talk too much about this first part because Dana's going to talk a lot about activity modifications and different types of splinting. The gist is that try and avoid the forceful pinch and sometimes using different techniques, jar openers and whatnot, at home. We also know oral anti-inflammatories can be helpful. As an orthopedic surgeon, I tend to be very cautious with prescribing oral anti-inflammatories. The last thing I want to do is take something that's bothering just your hand and cause a stomach issue or cause a heart issue. So sometimes, we'll talk about local anti-inflammatories, things that can be directly applied topically, or even more directly, we talk about corticosteroid injection. And those things, along with the therapy, are really the mainstays of our treatment. But ultimately, again, when those things aren't working is when we start talking about possible surgery. And with that, I'll turn it over to Dana to talk a little bit more about the different types of joint protection and other things that we really rely on to help manage this.
Thanks, Dr. Mackin. The first thing is we tend to continue to work through our pain. And the first thing I want to tell you is if you're doing something and it's causing pain, then it's probably not something good for you. So we have to change the way we do it. Our first line of defense when someone comes and sees me is to teach them how to protect their joints. And it's just basically trying to make sure we provide a minimal amount of stress to our thumb in this particular instance, or any joint that you have pain in. There are some basic principles. Motion is lotion, first of all. I always say that, but it's so true. Go ahead and go to the next slide. Some of the joint protection techniques, again, respect your pain, make sure you have a balance between rest and work, maintain your muscle strength and joint range of motion. I will tell you a lot of times when we see people, it's either because they're super tight or they're super weak, which I know is kind of a simple explanation, but that's the reality of it. Anyway, reduce the effort needed to do the job. Basically using can openers, things like that. One of the things I give patients is a little sheet of Dyson. It's basically so it sticks to whatever surface it's on. So for example, they put a piece of Dyson on the kitchen counter. They're going to mash some potatoes. They don't have to use their other hand to hold the bowl. The bowl won't move. Those kinds of things. Avoid positions of deformity. You know, if you're doing something and you're in an awkward position, it's probably not good for your joints. So change it and try to make it easiest. Using the most strongest, largest joints for the job, basically use your legs, you know, when you lift, or use the palm of your hand when you're trying to open a container versus using just your fingers. Go ahead and next slide. Use each joint in its most natural neutral position. I'm sorry, this is probably this is natural. We tend to, again, do one of these, or, you know, we're stirring when we could just stir like this. Avoid staying in one position for extended periods of time. To me, that's common sense, but you know, sometimes you can't, so work it out so you can. Timers, things like that. Avoid activities that cannot be stopped immediately, and use splinting. Splinting is probably the next biggest thing we really go for. But motion is lotion. So yes, we use splinting, which seems counterintuitive, but we use that to rest the joint, but we keep it moving. Go ahead, next slide. These are some of the splints out there. These are the one in the bottom left-hand corner. Jeez, I don't know my right from my left. Most therapists don't. I shouldn't say that about therapists, but that's one that we use definitely, like if we have to do a surgery, meaning Dr. Macklin has to do a surgery. Something long like that is typical of what we would put on somebody. The one above it is an eventual size after the surgery. But we also, if someone's really painful, we'll put them in one of those and rest the joint, especially at night. And then during the day, if they're painful all the time. The ones on the right, there's two types. Those are our favorite. I don't know if I'm allowed to say the brand, but Comfort Cool is the brand. I don't get any monies for them. I don't own anything in it. So, but they provide for us and people we've seen, this provides one of the best supports for that joint, but allow you to keep doing. You know, you can fit a glove over it if you need to. You can still wrap your hand around something. It's soft. It's not going to hurt if you go to pick up your grandbabies. Okay. Trying to think. Oh, this is some of the things that I like to go over as well. When I see patients conservatively. Coflex wrapping, it's like vet wrap. Basically, I do this in the clinic and I show people how to do it, but it's just kind of figure eight the thumb. It gives it that support, and it's a kind of a cheaper option than going out and buying a splint. The other thing I want to make sure of is that people are making sure that their thumb, this muscle doesn't shorten. So we kind of keep that stretched out. So we'll teach people to do that. And then also making sure they keep everything open. The other thing is make sure that we keep the muscles that open the thumb. We want to keep those strong too. Okay, Dr. Mack.
So ultimately, when those things don't work, that's when we start talking about surgery. If you ask 10 different hand surgeons exactly how they do the surgery, you'll probably get 11 different answers. Really what the literature shows us and our experience with patients shows us is that the most important thing is that when we're treating this with surgery is that we're removing the arthritis. Really what we're doing is, you can see down in the bottom left, this is where that really severe arthritis is. And essentially what we're doing is we remove that bone and we create a new joint. And that can be with other tendons. I know I'm often asked about, are there any prosthetics that we put in there? In the past there has been. Those did not work out so well. There are some new things on the market that have very early results, but that's not something that I would jump to do at this point personally. And then another thing, and I know that there were a few questions, and I will certainly touch on a few other topics. I know Dupuytren's was one thing that was asked about in particular. To talk a little bit about tendinitis, de Quervain's tendinitis. What this is, as you can see over here, it's very similar in nature to trigger finger, but it's on the other side of the hand. And what it is, it's a tendinitis of the two tendons that come off the base of the thumb. Again, they run inside of a sheath right here on the side of the wrist. A lot of times we'll see this in people who have been doing a lot of lifting. So we'll see it a lot of times in new moms, not as often in new dads, but we'll also see it in caretakers and people. I've seen it in people who had a really big move and were lifting a lot of boxes, but essentially develop inflammation around there, and it's aggravated by the things that those tendons help us do. So sometimes thumb extension, but also by bringing the wrist into ulnar deviation, that puts a lot of tension over here, and then bringing the thumb down. So that's what I would expect to see on an exam. The treatment for that, and again, I'll turn it over to Dana in a little bit to talk about bracing. Sometimes we also talk about anti-inflammatories. Steroid injections for this tend to be very, very successful. They have about a 90% cure rate with up to 2 injections, and typically safe to do while breastfeeding. The biggest thing with any steroid injection, especially if we're doing it close to the skin, it can cause fat atrophy, where the fat cells actually shrink or die. That does not reverse. Or sometimes the skin cells there will actually lose their pigment. If that happens, it does typically come back, but can sometimes take 3 to 6 months. Ultimately, again, if none of those things are working, we talked about going in and taking the pressure off of that tendon. So again, turning it over to Dana to talk a little bit more about the non-operative treatments for this.
Right. He mentioned seeing patients that come in after a weekend of moving. This is best treatment for it, is just to splint for 2 weeks, solid splinting, rest everything. They can come out to do very gentle range of motion, but otherwise you'd keep them in the splint for 2 weeks. And then we move forward to just doing some exercises. We can also, we're in the clinic, we obviously have some modalities that we can use and things like that. But go ahead, next slide, please.
Yeah, I was gonna say, just to chime in, this is one in particular that I don't love the over-the-counter the splints for. because a lot of TENS, they're circumferential, they push right where the problem is. So time and time again, I have patients who told me they've tried splinting, it made it worse. And a lot of times it's not that they're trying to do the right thing, but a lot of the splints push right where it's sore. And that happens for a lot of things. And that's where, again, I really rely on the hand therapists that I work with to be able to make splints that, because they're custom, they can cut holes where it's sore, whether that's a wound or a tendon issue.
Right. The splints, I love doing splinting. So anyway, exercise, once we kind of get everything calmed down, we want to do some exercise. I kind of threw this in there just so you had an idea of, like, it's not just, 1, 2, 3, 4. No, we have to really think about what we're doing, what kind of, there's different contractions, like when you bend your elbow, that would be a concentric contraction. And then we have where if I bend my elbow, but I'm still using this muscle, that's an eccentric contraction. And we want to use eccentric contraction to anything that's really been any tendonitis that kind of turns into a tendinosis. Chime in here, Dr. Macklin. Just because the tissue changes, so we need to change the tissue back. And by using eccentric contraction, it's worked. And like I said, we also use ultrasound or low-level laser light therapy, but slow progression, but most people do fine.
Absolutely.
I know there's.
I agree.
What'd you say?
I said, I agree.
Oh, thanks.
Before we get to the questions, I know that one of the big things was Dupuytren's disease, which I have talked about in some other talks, and I know that those are available online. Specifically what Dupuytren's disease is, and I apologize, I don't have a picture up here. Essentially, it's a thickening of some of the normal palmar fascia. And what we'll see over time is that can actually cause the finger to contract down. And that typically involves kind of the ulnar digits more so than the other digits, but it can involve anywhere on the hand. It does also have some relatives, in the feet. It's called Lederhosen disease, and doesn't necessarily happen in the same person. And when we talk about what causes it, a lot of it, we think is genetic. We also know that diabetes can predispose patients to it. And a lot of times we'll actually see it worsen after a trauma or kind of present for the first time after a trauma, whether that's a physical trauma or surgery, which is a form of physical trauma. And really over the last 15 years, our treatment options for that have opened up a bit. So the traditional treatment for that, we know that stretching doesn't really help stop it. But what we do know is that we essentially going in and either removing the tissues that are causing it can be really helpful. That's something, if I'm doing that surgery for, I also very heavily rely on our hand therapist afterwards, because that does create a lot of scar tissue. And it's something that we really need to get patients moving really quickly. And also, we put them into splints that they're wearing overnight. In addition to that, we talk about needle aponeurotomies, where we actually go and cut the contracted tissue. Or something that's more recent is talking about doing Xiaflex. Sorry, it's a collagenase injection. So something that we inject in there and actually can partially dissolve that cord, and then we manipulate to open up. Ultimately, the biggest thing to know with Dupuytren's disease is that it's something that, while we're treating it, we're not actually getting rid of the disease. We're really more treating the symptoms. And because of that, we don't jump in and do something at the first time we see a little nodule or something. We really want to wait typically until the MP joint is at least a 30-degree contracture, or if there's any involvement of the PIP joint, which is this joint over here. The reason why we don't jump in at the first sign of it is because if we do that, it's going to keep on coming back. So we really want to kind of make any intervention we do last as long as possible, and kind of move from there. So with that being said, I think kind of open it up to questions.
Great. Well, thank you so much for all the information. Very helpful. We have a lot of questions, unfortunately from my screen, some of which disappeared. So if you don't hear your question, if you want to send it again, I do apologize for that. We will leave this last slide up there, up here for you to see. So if you're interested in having an appointment with Dr. Macnin, you can call the number that we have on here, which is 440-732-4529. He sees patients in Solon, Mentor, and Chardon. If you are not located close to those locations, you can call 216-243-2028 for an appointment. If you would like to see Dana and have some physical therapy done on your hand or wrist, you can reach her at
Occupational therapy, sorry.
I'm sorry, at 216-551-9126. So we'll start with the questions. And one of the questions that was submitted multiple times was, and this is for Dr. Macnin, are you seeing a lot more issues, hand and wrist issues from people holding cell phones so much?
Yeah, that's actually something that I get asked a lot. I would tell you, it's kind of hard to say. I mean, I think certainly, repetitive things can certainly aggravate things. And, things like neuropathy, so numbness and tingling, especially so ulnar neuropathy is the nerve that goes by the elbow, the funny bone nerve, or even carpal tunnel syndrome, which is, again, the nerve kind of right here at the wrist. I'll see people who they wake up and their first thing they do is sit in bed with their cell phones instead of a book, but holding their elbow flexed like this and holding their hands up, that'll aggravate it. So I wouldn't tell you I'm specifically seeing things, but it wouldn't surprise me in the future if we do kind of see a new crop of things. I mean, if you compare what we see now to what hand surgeons took care of 20, 30 years ago, one of my mentors who was in his 50th year of practice when I was doing my fellowship, half of his practice was rheumatoid arthritis. And, we still certainly see patients with rheumatoid arthritis that have hand issues, but that is a much, much smaller percentage of what we're doing now. And a lot of that is because of the great anti-inflammatory medications, the disease-modifying anti-rheumatoid drugs that we have. So I think we'll always see things kind of shifting and, hopefully coming up with new ways to treat things.
Great. Thank you. Again, for all of our participants, we've reached about 30 questions that have been submitted. And this is a time-limited presentation. So again, feel free to reach out to any of our presenters here this evening, and their contact information is on this slide that you're looking at. The next question is, are there any surgical or other ways to fix knuckles on a hand damaged by rheumatoid arthritis?
So yes, from a surgical standpoint, a lot of times I'll see patients with this, and a lot of times I'll send them over to Dana or one of our other great therapists, because a lot of times we can manage the patient's symptoms, and it's really about finding out what the patient wants to be able to do, what the actual limitation is. And sometimes that can be solved with something as simple as a splint that a patient puts on for a specific activity that, maybe they do for an hour a day or, a couple times a week, and that's someone, if they're well served by that splint, then that's a great option. And I'll let Dana kind of touch base more on that. But, ultimately, yes, there are. I mean, we will do joint replacements on knuckles. And, sometimes that also involves some soft tissue repositioning. But yes, there are lots of different options I think that we have.
Yeah, there's hard splints that we can make like custom for a specific activity. There's also soft splints that right now, actually, we have kind of the ability to make just to, when you see people with rheumatoid, they kind of sweep over this way. So we can make a soft splint to kind of bring them back. you kind of have to work with the patient because you don't want to cause pain by putting a splint on. So we work with them, and we also always, I should say, do some sort of strengthening. I mean, be it light, but that will help them as well. And go over joint protection, obviously, and go over anything that can help them in the home.
Great, thank you.
Mhm.
So has several questions. It looks like we have a lot of people that have been told that they need carpal tunnel surgery. And the question is, are there any non-surgical options available?
So, so carpal tunnel syndrome is one of those things where we know that typically it's not something that's going to fully resolve on its own. The exceptions being if something during pregnancy or some reversible condition, and I don't mean to call pregnancy a condition. Someone said that to my wife once, and it was not. They got the other end of it. But things that are reversible, a lot of times we'll talk about bracing overnight. Again, the idea is when we sleep, we tend to bend our wrist. That increases the pressure on the nerve 2 to 3-fold. So sometimes keeping the wrist straight overnight is enough to give a patient relief. The caveat to that being is that, what we don't want to have happen is have the symptoms continue to progress to the point where they're no longer intermittent and they're constant and, worse and worse, because we do know that without treatment, without appropriate treatment, that there can be permanent damage being done to the nerve. And the biggest thing that I stress to all of my patients when we're talking about doing a carpal tunnel release is that really the goal of surgery, the goal of any treatment, is to stop it from getting worse. Because while we're good at taking pressure off of the nerve, we do not have any way currently of going in and fixing any damage that is already done to the nerve.
Thank you.
Right.
Another carpal tunnel question. I am about 3 years post carpal tunnel surgery in my dominant hand. I find wearing a wrist brace helps maintain proper keyboard/mouse posture and reduces flare-ups. But are there any contraindications to wearing a brace?
Well, I would say wearing a brace all the time can interfere with the strength. So I think it's good that you can get the muscle memory with the splint, but you need to start weaning out of it and hopefully doing some sort of strengthening. But you have to.
So I would echo that. I mean, a lot of times, I talk to patients, it's one thing if you're putting on for half an hour, just, here and there. But yeah, I mean, prolonged wearing of a splint, if it's not, if it's something that we might be able to rectify with strengthening, I mean, that's a great place where therapy can come into play and kind of work on building up the stamina because, with a lot of things, and it's the same thing we deal with, after a wrist fracture where a patient's been in a splint for 6 to 8 weeks and not able to use it, then it takes another, 3 to 6 months to kind of get back to normal activities just because we have to rebuild the strength. If we were all 5 years old, that would happen in about 2 days.
Right.
Unfortunately, we lose that at some point. So.
Okay, thank you. This question comes from Kate. Kate notes that I have been having numbness and weakness in my hands related to exercises such as push-ups and weightlifting. I use push-up handles for anything I can that is wrist weight bearing. Is there something more I can do to help alleviate this? Perhaps any types of exercises?
Again, strengthening. And strengthening, and when you do strengthening, you really want to be cautious that you don't go from 0 to 60. And then what were you going to say, Dr. Mackin?
Oh, I was going to say, I mean, so a lot of times also it can be about where you're putting pressure on your palm or your wrist when you're doing those exercises. I have patients who, they ride their bicycle and, just the handlebar hits them right here. And, it can depend where your numbness is. So I'll have some patients who they get numbness in their small and ring finger, and it's because there's too much pressure right on the ulnar nerve here. Or sometimes it can be kind of right over the carpal tunnel, right over the median nerve, and the numbness will go into these fingers. Or sometimes it can just be more an issue of kind of a circulation issue as well. So, if it's only happening with certain activities, if there's a way to modify that activity in such a way, that's, I think certainly I'm a big fan of using push-up bars or doing push-ups on knuckles.
Yeah.
I was just talking to another one of our hand therapists today who used to work in the military, and this is the worst position possible to load a wrist. Your wrist was not designed to take a load like that. So using things like push-up bars, generally is good, but if it's causing numbness, I guess the other question is there numbness at any other time during the day, and is it something else that could be addressed as well?
Great, thank you. This question comes to us from Dale. He noted that I have some osteoarthritis in my knuckle. At times it sends pain up my middle finger. What can be done for this?
Do you want to take that, Dana?
Well, I could, splinting, but go ahead.
No, so for me, if a patient comes in, we talk potentially about splinting. Sometimes also just kind of a form of splinting using like a Coban or a soft tape just to give a little extra support. Sometimes, patients will notice that their swelling is worse in the morning. That's where something like an arthritis glove or a compression glove can be helpful. It helps kind of reduce the inflammation, which can also help. From a non-operative perspective, also sometimes we consider steroid injections. And then again, if none of that stuff is working and it's interfering with your lifestyle, then sometimes, either fusing the joint so it doesn't move, it's not painful, or if motion is going to be really critical and the x-rays suggest that it would be reasonable, sometimes we'll do a joint replacement.
Great, thank you. This question is from Joyce. She noted that I had carpal tunnel surgery on both hands years ago. Within the past few years, I have been having burning pain on the outside edges of both wrists. Is there any treatment for this type of wrist pain?
So I'm not entirely, just from the question, I'm not entirely sure if that wrist pain is related to the carpal tunnel releases or not. I mean, I think the one thing I would start off by saying is that carpal tunnel syndrome can come back. It's, we're not leaving the nerve open to the world, so that's something that we always worry about. If it's something that's been ongoing since the time of surgery, sometimes patients will run into pillar pain, which is pain in some of the muscles. That's where I rely a lot on my therapist to help out with. Or it could be something entirely different altogether and might be worth getting looked into further.
Yeah, that's kind of a hard question to answer.
Okay, thank you. So our next question comes from Jeff. Jeff is a 65-year-old with swollen knobby joints and pain at the base of his thumb. He wants to know, should I ask a physician to refer me to physical therapy?
Yeah.
Oh, yes, I'm sorry. Use
I
my
saw you
words.
nodding.
Great,
Yeah,
thank you.
go see Dr. Macklin and he'll send them to us.
Yeah, so I think, I think either place is a reasonable place to start, whether that's with one of our hand therapists or with me. We can talk over everything and, just because you see me doesn't mean you're going to get surgery. Dana will tell you that a large percentage of my patients end up coming to see them and end up not needing any surgery, which is great. I'm a surgeon and I love to operate, but what I tell all my patients, I don't like operating on people who don't need surgery, because that would make my days very long. And so.
Right.
Great. So earlier we had a slide, you were showing some black and white braces. And the question is, are they available in drugstores and when should they use them? And then also, in terms of usage, should they wear them all day or only at night when sleeping?
Um, you're talking about the Comfort Cool thumb spicas. I'm an internet person, so I tend to say go to Amazon, or you can Google it, but the cheapest place I've ever seen them is on Amazon. You do have to know the circumference of your joints here to get the right size. Depending on the severity is how much you should wear it. If you're really painful all the time and you don't want to be in a hard splint, then I would go with the long one and keep it on all the time. Obviously coming out with hygiene and things like that. The shorter one is good when people need support, that they want to keep going. They want to, when they're working, they just want that support. So you know yourself best. So if you put that on and you're like, okay, this is good, but let me try to take it off. Because again, we don't want to get people dependent on the splints either. I hope that answers the question. But
Yeah,
Drug Mart might have them, but I have not seen them.
Yeah, I was gonna say, I mean, so a lot of, I'll refer patients. I mean, we have some splints in the clinic, but for patients who haven't met their deductible or what have you, I have a lot of patients who do exactly what Dana said, is buy them online, or a lot of the drugstores or,
They'll order them for
a lot of the other places will have braces. And sometimes you're able to try them on. I don't know, they're probably not so much currently during the pandemic. But if you do buy it online, a lot of them actually have sizing charts that allow you to measure. The biggest thing that I tell my patients is make sure you're buying the left side or the right side, because you don't want to buy two right sides.
Right. Correct.
But yeah, and it's interesting because, there's a reason why, and I agree. I mean, I think I have a lot of patients who have had a lot of good success with that type of splint. There's a reason why there are over 100 different types of splints. If you search for it, it's because there's not necessarily one that works for everyone. So I have some
That's
patients
very true.
love a certain splint for one activity and don't like it for another. Some of them you'll see pictures of people playing golf wearing them, and it really depends on what fits best for you and what activities you find that you need to wear it. And if you can wear it for a certain activity and that allows you to take it off and do something else, then great.
Right.
Thank
Well
you.
said.
Dana, you had mentioned Eucerin as a treatment for scar management. The question is, what type of Eucerin? And then also, Donna noted, I have Eucerin for very dry skin and it's called Advanced Repair Lotion. Would that work on scar management?
Yes, definitely. Eucerin, I think Cetaphil is another one. Eucerin, any of them, I tend to really like the thicker one. I can't remember what it's, there's like on the Eucerin stuff, there's like this thinner and thick. I go for the thick. But at work, I use the one you're actually describing.
Great, thank you. This next question is from Colleen. If I had a steroid injection in June of 2020 for DeQuervins and it helped, but pain is reoccurring, can I get another steroid injection now?
Yeah, so typically, with DeQuervains, I say, the general rule of thumb is I like to do no more than 2 injections, but I think 2 injections is certainly reasonable. Second injection can still be really helpful. Usually the rule of thumb with all steroid injections is we like to wait at least 3 months. You certainly qualify. So yeah, I would tell you that's a reasonable thing to do. And, if it does come back again, that's when maybe it's time to start considering surgery, which would hopefully be more permanent. But,
and I would say if you end up getting a second shot, it helps with the pain, but the underlying problem is probably still there. So maybe give us therapists a shot and try to change the tissue and make you feel better.
Great, thank you. This next question is from Riley. Is there a true cause on how ganglion cysts form?
So, ganglion cysts, it's interesting. It's, they're kind of fluid collections that come out usually from joint spaces. Not always. Sometimes we'll actually see them come out of the flexor sheath. It's really anywhere that there is fluid. What happens is there's a weakening in the sheath or the joint capsule, and a little bit of fluid is able to get out, and it kind of sits there. It's almost like a one-way valve forms, and so that fluid will come out, but it can't get back in, which is why sometimes we'll see them grow. Every now and then something might happen. It might partially pop, and that's when it gets smaller, or sometimes there's not as much inflammation, and that fluid has a chance to kind of work its way out. So that's kind of ganglion cysts in a nutshell. They aren't inherently dangerous. The one spot where I worry about them the most is if they're at the DIP joint, so the joint right before your fingernail. If they are draining, that becomes more concerning to me, because if fluid is actually physically coming out of your body, that also means that bacteria and bugs can get in, and then I start worrying about infections, and that's where we start. Treatment becomes a little bit more time sensitive.
Great. The next question, if it turns out pain may be caused by carpal tunnel syndrome, is there any other testing other than EMG?
So, carpal tunnel syndrome, and it's interesting, it kind of depends which society you look at. So carpal tunnel syndrome is inherently, it's really a clinical diagnosis. EMG, nerve conduction studies, that can certainly be helpful. And a lot of times we'll use those in situations where either A, it's not entirely clear, or B, we want to somehow quantify the extent of the nerve injury. The other test that actually has become much better, and I think we have a really great team at UH, is also a neuromuscular ultrasound, where they can actually, they'll measure the size of the nerves from your upper arm all the way into your hand. And by measuring the cross-sectional areas and kind of following them along and looking at their properties on ultrasound, that can also, make a more definitive diagnosis.
Great. Next question comes from Julia. What are your recommendations for conservative treatment of Heberden's nodes?
Are they painful?
That I don't know. Did I pronounce it correctly?
Yeah, well, kind of. I mean, I know what you mean.
Okay.
Heberden's and Bouchard's. Yeah, if they're not painful, I tell people to leave it alone. If it's painful, sometimes, it's really the joint that's painful. And, sometimes either considering an injection, sometimes splinting again. I think that's another one where, just for a quick thing in clinic, I'll tell them to put a little piece of tape or some type of bandage just to give a little extra support. It almost acts kind of in a proprioceptive way, so it's there. You're kind of more purposeful with it. Or splinting it for a part of the day to kind of help reduce some of the inflammation. I think I already said steroid injections. And the other thing that I've had patients had some success with, and I can't sit here and tell you it's super evidence-driven, but diclofenac gel, which recently became over-the-counter, I'll have patients who will apply that in that area, and your finger joints, your hand joints are close enough to the surface that maybe that can help out as well. It's an anti-inflammatory gel.
Are you talking about the one that starts with a V?
Yes. Yeah.
Okay.
Yeah. So the brand name for it that she's talking about is Voltaren. Right?
Okay.
We weren't allowed to use any brand names in my training in my medical school, so it's an old habit.
Yeah, I didn't know either. So okay. But yeah, Voltaren, we've had some patients are like, I can't believe they didn't tell me about this a long time ago, and it's now over the counter. So
yeah, it's over the counter. I mean, you can go, Walmart has this massive box of 3 tubes, Costco has it. I mean, it's everywhere now. And the nice thing is actually it has a really nice top to it. I don't know if you've seen this, but it's designed for people with arthritis. So it has a triangular top, so it's much easier to open and close.
Oh, okay. See.
So we're about out of time here. Would both of you mind going an extra 10 minutes so we can answer some more of these questions?
I'm here.
Me
Okay.
too.
All right. Thank you so much. This next question is from Dennis. How long does it take for nerves to heal? And I had surgery in early January for Guillain syndrome and still have vascular throbbing and discomfort, but I think it is slowly getting better.
Yeah, so I mean, nerve healing is usually slow. That's the best way to put it. I mean, so if a nerve is cut and we're waiting to see improvements, a nerve heals at a rate of about 1 millimeter per day. And, the same thing goes for when it's compressed. So carpal tunnel syndrome, sometimes people will get good relief, right away. But, from here to the fingertip on me is probably about maybe 15 centimeters. I mean, so, we'll see improvements after nerve injuries and nerve repairs. I mean, it can be measurable differences, 3 to 5 years. A lot of times we get a lot of stuff within the first few months, but it can take a while. I think the biggest thing is, and this is, again, I rely on the therapist, so keeping the digits, the tendons, the muscles all stretched out so that when
And
hopefully
loose.
that gets there, they're ready to receive it.
Right. And keep everything loose, scar management. Also make sure you're not aggravating the area. But yeah.
Yeah. The other thing is just with scar tissue, it's usually at its worst 6 weeks after surgery or after injury. I have a lot of patients that get nervous because a lot of times their incisions will get red, they'll get thick right around 6 weeks. And actually, when I was in Connecticut, I don't know if there was just really good access to primary care doctors, but it was not uncommon for patients to be put on antibiotics by their primary care doctors around 6 weeks because it almost looks like there's an infection. When in fact, what it is that it's when your body is really at its busiest, reorganizing all that scar tissue. And so a lot of times at around 6 weeks or so after surgery, patients will get more sore in the site of their surgery or injury. And this is something that happens all the time, even with paper cuts. We don't really pay much attention to it. But a lot of times, a month later, you bump it and you go, oh, that's more sore than it was a few days ago or what have you.
Yeah, sometimes after surgery or an injury, we avoid the area and that area can get very hypersensitive. So if that's happening, like if it's been protected and now you just kind of want to go back to normal, but you keep hitting it and it's burning, that's when, again, occupational therapy can be helpful. And it sounds like maybe it might be in this case, but anyway, go ahead.
I use the analogy of a baby's feet. They're soft when they start, but by the time you're 30, 40, 50, 60, 70, you usually have some calluses on there, and that skin is restarting all over again, so sometimes it can be really helpful. I do have some patients that are sometimes hesitant to go see a therapist, and what I try and remind everyone is that Olympic athletes and all these professional athletes all have coaches.
And guidance.
It's someone who's been there, done that lots of times, and someone who can kind of push things so that you get better and get stronger and kind of push some of those boundaries that otherwise, you may not quite get to.
Great, thank you. This next question is from Deborah. She notes that she fell and broke her wrist years ago, and now she's having pain in that wrist. Should she be alarmed and go see a doctor?
You don't necessarily need to be alarmed, but I think that certainly would be something that's reasonable to have looked at. Things that we worry about years after a wrist fracture, it can be post-traumatic arthritis. So if it healed in a slightly different position, if it was fixed with surgery, sometimes we worry about irritation from the hardware that might be in there. There are a lot of different things, and sometimes it might be something entirely unrelated to the initial thing. But I think it would certainly be reasonable to, get some new x-rays and be evaluated for that.
Great. This next question is in regards to carpal tunnel, and it's quite lengthy. So I had carpal tunnel surgery 4 years ago. From the time I had it, I started having this pain in the fleshy part of my thumb, and it would radiate up to my elbow, kind of like a tight, painful tendon. I would massage and stretch by pulling my hand over and back and flexing my thumb. Is there anything else I should do?
I mean, I would say that that's something that I probably would want to evaluate in clinic. Whether that's nerve related, whether that's potentially a mild trigger thumb that's been hanging around, or just scar tissue related.
It's a different issue, probably.
Yeah.
Right? You think it's a different issue?
Well, yeah, I'm just wondering. I mean, if it's been present since the time of surgery, then I don't know for sure. But I think that would be something that I think I could list a lot of things that it might be, but I think a hands-on evaluation would be the way to go for that.
Great, thank you. This next question, a patient of mine, a former world-class marathoner, experiences aching pain in both hands that starts in the hands and moves up to the elbows about 5 minutes into a run. The pain doesn't go above the elbows, doesn't happen when he rows or bikes. Any possible etiologies or solutions?
Did you see what I was doing? When we run, we shoot fluid to the end of our fingers. So depending on, does he never gets any type of numbness or tingling any other time? That's a question,
Yeah.
but go ahead, Dr. May.
Yeah. No, so, yeah, I would agree. I think, again, there are definitely some potential things that I would be concerned about that I think would be easier to figure out, just exactly where the pain is coming from, whether that's something potentially related to some of the tendons in the forearm and the elbow, certainly different muscles that are used during rowing and cycling, and, just, definitely activating. I've had some patients with bicep tendonitis from running that they don't get those symptoms anywhere else just because they're running and, really stiff with their elbows, which I'm guessing he's not if he's a world-class runner, but I think, there's certainly some things that might be worth evaluating in person and, really seeing exactly where the issue
mechanics of what he's doing too.
Great, thank you. I had a few questions regarding this. This is from Bonnie. Is there a certain type of jar opener or brand that you could recommend for people that have pain at the base of their thumb?
So, I'll let you take that, Dana.
Well, there are countertop jar openers that you can get. I'm an Amazon user, so I would just Google and do my homework. I haven't personally checked on that, but use of Dyson is great. Again, you can Google a lot, and you'll probably get a lot of good ideas.
Yeah. So we actually just purchased a couple in our house. I'll be honest with you and tell you they're totally off brand. They're totally off brand. They're not any specific brand. I think the question kind of becomes, they actually have one that you can mount underneath a counter. Now, it kind of hides up there pretty well. The nice thing with that is that then you can use both your hands. You're not holding the jar top at all with it. So that can be really nice. The issue with some of the handheld ones is that you're still gripping somewhat. So that's just something to think. They certainly lessen the force that you need to open it.
Mhm.
But yeah, I think, just a lot of this stuff, even if you don't have arthritis, I'm a huge fan of prevention. Why do I need to exert more force than I need to exert if there's something that can help make my life easier? So,
Right.
Great, thank you.
Maybe avoid issues in the future.
Well, I'm going to read this and then we're going to have to close out because we did go an extra 10 minutes. And I do apologize to the few people left whose questions we did not get to. But Janet wanted to pass along to both of you that she thought this was an excellent presentation and information source, and wanted to thank you both so much for hosting this and addressing real life motion and activities. So definitely thank you. And thanks. And absolutely. And thanks to everyone for joining us this evening, and for Dana and Dr. Macklin, thank you for sharing your expertise and advice with everyone. A couple of reminders for the audience. We are going to be emailing you a link that will have, or you will receive an email that has a link to this presentation. So if you want to view this again, you could do so. And again, we have the slide up. If you're looking to make an appointment with Dr. Macklin or with Dana, the numbers are up here. For Dr. Macklin, it's 440-732-4529. For Dana, it is 216-551-9126. And if you're looking for some more information, just visit uhhospitals.org/ortho. I think in looking at a lot of the questions that were left here, I think if you go to the website, you'll find the answers that you're looking for. So again, our apologies for not being able to answer all of your questions. This continues to be a very popular health talk, so I'm sure we'll have another one here before the end of the year. And with that, that concludes tonight's session. Thank you so much to everyone for attending, and we hope that you'll join us for future webinars. Have a great evening.